This morning we'll be discussing placement of 4 veneers. These are actually Emax veneers on the 4 maxillary incisors. Hit the blue link in the description below and subscribe to dentistrymasterclasses.com if you want the really good stuff and the organized library of all the Dental Minute videos plus complete comprehensive cases. You can see how these teeth had some bonded composites on the teeth, and dentist had ground the teeth off and they were uneven. Now, as you know, with composite, you can place composite within the confines of the tooth. What that means is you don't want to hang it off the end of a tooth. Like in this book, see, I can place the composite as long as the existing part of the tooth is, but I can't put it down here. The patient will break it off. Same thing in these cases. If the patient does any grinding at all, you can fill in this divot right here and make it even across the front, but I couldn't lengthen that entire incisal edge by a millimeter or two, or the patient's going to break it off. See, I've placed composite this long, but if I'm lengthening the tooth, that's when you should go with a veneer, unless you know for sure the patient doesn't grind their teeth at all and they're wearing a night guard. But even if they don't grind their teeth, biting on things is the leverage with this cantilevered part off the tip of the tooth. It's probably going to fracture. And remember, you don't want to make the patient's problem your problem. If you restore that tooth and the patient breaks it a month later, I don't care if it's your fault or not, they're going to look to you, even if you discussed it ahead of time. So don't get yourself in that situation. Only do those procedures that you can stand behind. That's why I'm not a fan of big fillings. You talk about making the patient's problem your problem. You place a big filling in a tooth that had very little tooth structure, like a big MOD, and the patient breaks that tooth, they're going to forget you said that filling was too big for the tooth. It should have had a crown. I'm not going to place that big filling. So see, in this case, the tooth is worn, and so I can restore it to that level with bonded composite like I've done right here. This is some bad bonding right here, and I've replaced that, but it's the original length of the tooth. So when you've got a situation like this, you really, if you try to extend the tooth this length and this length, because you know that incisal plane of the central incisors should be parallel to a line drawn between the pupils, which represents the floor or the earth. If you lengthen it to here, unless you see no evidence of wear, which I see these teeth are worn, there's a pretty good chance the patient's going to fracture it. And I don't like to do it because, like I said, I don't want their problem to become my problem. And this could be a never-ending circle. You can see she's got a big composite filling here, another large composite filling right there. These teeth I would restore with bonded composite to even that jagged edge, but I would not lengthen these teeth because of the reasons I just gave you. So we've bonded the incisal edges of the lower centrals. That was a good place to place composite bonding, and then place 4 porcelain veneers on the incisor teeth. You see here's before and after. You can see the composites. I'm going to show you what I do if you're replacing a large composite while you're placing a veneer. I think this will be interesting for you. Incisal edge position, you can see it's not parallel to the pupillary line here. It is parallel to the pupillary line here, and a line drawn from cuspid to cuspid is very close to being parallel to the lower lip line. So the patient actually came to see me because she was so unhappy with the outcome of this when the dentist had bonded the teeth and then ground them off. And it was a really big thing for her. So that's how we ended up placing veneers on the teeth. So the first thing we do in a case like this is wax it up to the ideal. You can refer to the video on wax up, and what I'm doing is making the incisal plane ideal, and also if we're placing veneers, waxing the teeth up about a 1/2 millimeter to 1 millimeter thicker, and we're going to make a matrix off of the waxed up model and use that as the matrix for the provisional veneers. The reason we wax it up a 1/2 millimeter to 1 millimeter thicker on the facial is because if you make the matrix off the pre-op model and then you only reduce the facial a 1/2 millimeter, which is the norm for a veneer prep, that veneer provisional is so thin it's very difficult to work with. So by waxing it up and making the matrix off of the waxed up model, the veneer provisional is thicker and you've got something that you can work with. You can see how we've made it thicker here. Again, refer to the article on how to use the waxed up model for veneer provisionals. So first thing we're going to do is place topical anesthetic, and this is an anesthetic we have made by pharmacy. It's compounded and it contains 100 milligrams of lidocaine, 100 milligrams of procaine, and then tetracaine. And we place that first. Then I spray the area with hurricane topical anesthetic, and then I'm blowing it in with my air syringe. Now this, I can't tell you exactly how it works, but I'll tell you when you do it like I'm showing you, it will be totally painless. The patient won't feel anything. In my mind, this air syringe blows that topical anesthetic a little bit into the unattached tissue, and then you come back with a 30 gauge needle, Sitness plane, which is pH neutral, and you barely go into the unattached gingiva, just barely with the tip of that needle, and just tap the end of the syringe. Then you slowly move the syringe further into the tissue, and as you do, you're tapping the end of it, keeping the Sitness plane ahead of the tip of the needle. So the original teeth are about 9.5 millimeters long, and you know the average central is 11. So what are we looking for here? I want to be sure that there's tooth display, that there's central incisor display when the patient's lips are in repose, when they just go, ah. Now you've got to take into account the type of lip in relation to the teeth. There's the flat lip, which most men have. There's the moderately arched lip and the maxillary arched lip when the lip's in repose. With the flat lip, you want to be sure there's some tooth display when the lip is in repose. Otherwise, it looks like the patient has no teeth. A moderately arched lip will display about half of a tooth when the lip's just hanging, when it's in repose. And a maxillary arched lip will display the full tooth and sometimes even the tooth and some gingival tissue with the lip in repose. I've published an article on that we have in the articles of dentistrymasterclasses.com. It's really interesting because I've studied these for many years. Okay, so 10, so we know we've got another millimeter at least to work with here. So the first thing I do is I tip the patient up in the chair, so their face is parallel to my face. And I use this thin burr and I cut right through the interproximal space between the central incisors. And I want this cut to be perpendicular to the pupillary line. I'm not trying to make it in the center of the face. Remember, midline is of little or no consequence. You really don't try to change the midline because the midline is a skeletal situation. So if the midline was off a little bit, don't try to move it over to the center. Just be sure you make your cut between the centrals perpendicular to the pupillary line, so it's perpendicular with the center of the face, not necessarily in the center of the face. That's of no consequence. Don't ever try to change that. And certainly don't worry about the central incisor, the interproximal line between the upper centrals being the same as the interproximal line between the lower centrals. that's of no consequence at all. I can't tell you if mine are lined up, so don't ever worry about that. But do this with the patient sitting up. If you try to do it with the patient laid back in the chair, you're not oriented correctly, and it may not be perpendicular with the pupillary line. You don't have to sit them up for the cuts between the other teeth, but between the centrals, they should be sitting up. Now I'm going to do the same thing between the central and the lateral, and don't cut, between the, the central and the lateral, then the lateral and the cuspid. So be sure you try not to touch the cuspid. Now I prefer a straight burr, a straight diamond burr to a flame-shaped, because I want to be sure that the veneers will draw, that the preps will draw. So I like a straight burr, straight diamond, just a thin straight diamond. There are different types, and I really like a diamond with a little roundness on it. If the tip is just comes to a real point, the diamonds on the tip of the burr go away pretty quickly. This is an occlusal reduction diamond. We call it a hat burr. And you want to also sit the patient up when you're adjusting the incisal edges of the central incisors to be sure they're parallel to a line drawn between the pupils. Now, since we want to lengthen these teeth just a little bit, and you'll remember the presenting teeth were only about 9.5 millimeters long. 11 millimeters is the average. So if I'm lengthening them 1 millimeter to 1.5 millimeters, I don't have to adjust much on the incisal edge. All I want to do is flatten it. So I want to flatten the edge of the centrals and the laterals, and be sure the laterals are a little bit shorter than the centrals. You always want the central incisors to be the longest teeth in the incisal plane. And so she's sitting up in the chair, and I'm just flattening it because I'm going to increase the length of the centrals about 1.5 millimeters. You'd want to cantilever as little porcelain or lithium disilicate off the tips of the teeth as you can, and about 1.5 millimeters is the ideal amount of material cantilevered off the incisal edge. See, so now we're about 9, a little bit more just to even it up. This is a coarse barrel diamond, and I'm cutting my 0.5 millimeter depth cuts into the teeth. And before you start this, you want to view the incisal plane from the incisal edge to be sure that the teeth are all in the correct arch alignment. If they're not, you want to first cut any tooth that's facial verted back into the arch alignment. In this case, they were all aligned, so we didn't have to do that. But once you cut it back in the arch alignment, that's when your veneer prep begins. So in this case, we're just removing about 0.5 millimeter of tooth structure on the facial, and be sure that you only remove about 0.3 of a millimeter in the gingival facial area, because this enamel is much thinner. It's only about 0.5 millimeter thick in the gingival facial area. So we'd like to keep the preps in enamel if possible. The body of the tooth has thicker enamel, so you can make the preps, you can, no problem with a 0.5 millimeter reduction there, but I usually just thin the enamel in the gingival facial area. See how I'm just thinning it right there. I'm not cutting it a full 0.5 millimeter deep because I want to keep the preps in enamel. Remember, the bond to enamel is much stronger than the bond to dentin. It's okay to have a prep in dentin if that's what the hand you're dealt, but if you can, keep it in enamel, because it's going to be much more, the bond's going to be much more stable. And what we'll do is come back, if we do have a little edge on the restoration at the gingival margin, we'll just come back and polish that once we seat the restorations. I want to be sure to round all the line angles except the incisal palatal line angle or the interproximal palatal line angles. You want those to be 90 degree. You don't want to taco this prep onto the palatal. You want the incisal preparation of the veneers to be flat, just like that top right there. Flat, not tacoed. So I'm rounding the facial incisal line angle and the interproximal facial line angle of those teeth. No right angles except on the palatal. Then I'm coming back with a fine flame diamond and placing my margin. And the margin is about 1 millimeter subgingival on the facial surface, about a 0.5 millimeter subgingival into the sulcus interproximally. The key here is you don't want to invade the biologic width. So you have a sulcus and then you have junctional epithelium or attached gingiva once you get about 1 millimeter into the sulcus. So you do not want to prep into the junctional epithelium. If you do, once you place your restorations, it's always going to be puffy and red and inflamed. So never go past the bottom or the apical part of the sulcus. Keep it in the sulcus. So normally I'm about 1 millimeter in the sulcus on the facial and about a 0.5 millimeter interproximally. Because these interseptal fibers, the periodontal fibers interproximally, are very dense and the sulcus is not very deep. So be sure you don't invade that biologic width. That's a critical mistake. So now I'm rounding, rounding, rounding. So you don't want to prep them like a crown. You don't want to take 1.5 millimeters of tooth structure away. When you get through, the prep, when viewed from the incisal, should look like the back of an armadillo shell. Now, a lot of you in other countries don't know what an armadillo is. This is a Texas and southern United States animal, but see how that is rounded. Everything's rounded. That's how the prep should look when viewed from the incisal. So I'm just barely subgingival interproximally and about 1 millimeter facially. And I'm rounding these line angles and corners. You don't want any square angles or it creates a fracture site for the veneer. Now what about these composites? If they're stable, they're fine. Just leave them. What if you have interproximal decay? Leave the decay until you seat the veneer. And I'm going to show you how to deal with that here in a minute. Don't remove the decay and place composite fillings when you're prepping the veneer, because if you do, your unfilled resin, your luting cement for the provisionals will stick to the composite. So don't replace them until you seat the veneer. Don't remove the decay and place the composite until you seat the veneer. I'll show you in a minute what I'm talking about. Now, why do the preps look like this? Remember, they have to draw, and most teeth have bulges, and so you've got to prep through the bulge and be sure that the veneer will draw onto the tooth. You can't have a prep like this or like this. It's got to draw. Makes it easier because you're not including the palatal surface or the lingual surface. So these are the preps. See, everything draws. See how it looks like the back of an armadillo shell. Taking a shade with a color correct camera, and we've got a video what to send your lab technician for a veneer case, and then we've got another case in Dentistry Master Classes, shade matching difficult cases, and it shows you how to do that. So refer to those videos in the organized library, video library in Dentistry Master Classes. So these are the provisionals. This video is on tooth preparation. And so you can refer to the other video on how to fabricate provisional veneers and crowns. Here's the provisionals again and the finals. And that's the Dental Minute. These techniques work, and they work every time.